extrapulmonary tuberculosis, different forms of extrapulmonary TB. Tuberculosis classification, we must start from classification of TB, several words only. And after that, we must continue about extrapulmonary form of TB, especially about tuberculosis of central nervous system. I'm sorry. This is result of yesterday lectures. About classification of clinical forms of tuberculosis. Clinical forms of TB are presented in the clinical classification and in accordance with which all doctors of TB service of Russian Federation work. The lungs are the basic organs affected by tuberculosis. According to statistics in Russia, in our country, we detect near 80% of patients with pulmonary tuberculosis and near 20% of patients with extrapulmonary form. But what about Europe? According to statistics in Europe, near 60% of patients with lung tuberculosis and near 40% of patients with extrapulmonary forms. What's problem in these results, in this statistic? I think that we have, in our country, we have not so small problems with early diagnosis of extrapulmonary tuberculosis. You must remember, early detection of TB, not so important, lung tuberculosis, extrapulmonary form of TB. Early detection of TB, the main purpose of physicians in different polyclinics, hospitals. Physiologists must use final diagnosis, differential diagnosis, and main purpose of physiologist, treatment, organization of rehabilitation, but early diagnosis of TB, different form of TB, the main purpose of different polyclinics and hospitals. I must continue. The lungs is the basic organ affected by Mycobacterium tuberculosis. But Mycobacterium can affect and cause the development of TB in different organs except hair and nails. Such clinical forms of tuberculosis are called extrapulmonary tuberculosis. Non-pulmonary, or more correct term, extrapulmonary tuberculosis. And now we must continue about some words about classification of clinical forms of TB. Among the clinical form of extrapulmonary tuberculosis are particularly significant tuberculosis of meninges, central nervous system, tuberculosis of intestine, peritoneum, mesenteric lymphatic system, tuberculosis of peripheral lymphatic nodes, tuberculosis of bones and joints, and especially important question, spine tuberculosis, tuberculosis of urinary and genital organs, tuberculosis of skin and subcutaneous tissue, TB of eyes, tuberculosis of other organs is a clinical form of tuberculosis of various organs which are rare. For example, tuberculosis of liver, spleen, heart, adrenal, pericardium, and etc. And I must repeat several, all forms of lung tuberculosis, pulmonary tuberculosis. You must remember information from first semester of our discipline. All clinical forms divide two main groups: primary tuberculosis and secondary tuberculosis. Now about primary and secondary group. Next, between main forms between primary tuberculosis intoxication, TB of intrathoracic lymph nodes, primary tuberculosis complex, and sometimes TB pleurisy as primary form. But more often, TB pleurisy we diagnose it as secondary form of TB, as extrapulmonary form of TB. What about secondary tuberculosis, secondary form of pulmonary tuberculosis or lung tuberculosis? Disseminated tuberculosis, acute, subacute, and chronic forms. Next, focal tuberculosis, infiltrative tuberculosis with different types of infiltrates, such as broncholobular, around type of infiltrate, cloudy-like, peristaltitis, labitis, and hard form of infiltrative TB, casus pneumonia. Next form, lung tuberculoma. Today we must continue about tuberculoma, but not about lung tuberculoma, about brain tuberculoma. Next form of lung tuberculosis. Tuberculosis, fibrous cavernous tuberculosis, and cirrhotic TB, main forms of lung tuberculosis. Please repeat information from first semester for the start of our cycle in this semester. Next. What about statistic about clinical forms of extrapulmonary tuberculosis? On first place, between different forms of extrapulmonary TB, on first place, TB of bones and joints. And big part in this form main place in between different forms of bones, joints, tuberculosis, TB of spine tuberculosis, TB of spine. Next, on second place, according to statistic, TB of urinary system, urinary system tuberculosis, kidney tuberculosis, ureters, and TB of urine bladder, and those patients with, as a rule, we diagnosed urinary system tuberculosis very late. This is bad result of diagnosis in different polyclinics and hospitals. Next, TB of peripheral lymph nodes. Lymph nodes, and next, skin tuberculosis and TB of central nervous system tuberculosis, skin tuberculosis. And what about TB of eyes? We detect this clinical form very rarely. Now we must continue about clinical form of extrapulmonary tuberculosis, and we must start from clinical forms of TB of central nervous system. This group include tuberculosis meningitis, brain tuberculoma, tuberculosis brain abscess, and tuberculosis encephalopathy. At first, clinical manifestation of this group are arrest. Often, this leads to diagnostic errors. Tuberculosis of meninges and central nervous system, CNS. Tuberculosis of meninges and the central nervous system begins from the moment of hematogenic dissemination of Mycobacterium tuberculosis to the nervous system and structures surrounding the brain or spinal cord and causing meningitis. What about risk factors for TB of central nervous system? Main risk factors for central nervous system tuberculosis have been identified. Children and HIV patients, patient with malnutrition, recent measles in children, alcoholism, and especially very important group, especially in real time, patient with treatment with immunosuppressive drugs, especially now when many doctors using this group, especially biological gene engineering drugs for the treatment of COVID infection. So those patients with high risk of TB, especially of TB with multi-drug resistance, especially of generalized form of TB, and especially of TB of central nervous system. We must continue about pathogenesis of TB of central nervous system. Prior to the containment of the infection, bacilli are filtered into draining lymph nodes. And there exists low-level bacteremia in which Mycobacterium tuberculosis disseminates to distant sites in the body. This hematogenic seeding occurs most frequently in regions of the body that are highly oxygenated, including the brain. A complex interplay of host immune factors and Mycobacterium tuberculosis virulence factors in the end determines whether or not the infection is contained and whether or to what extent the dissemination of the bacilli leads to clinical disease. For central nervous system tuberculosis, the disease begins with the development of small tuberculous foci, rich foci in the brain, in spinal cord, or in meninges. The location of those foci and the capacity to control them ultimately determine which forms of central nervous system tuberculosis occurs. Central nervous system tuberculosis manifests itself primarily as tuberculous meningitis and less commonly as tubercular encephalitis, intracranial tuberculoma, or tuberculosis brain abscess. In nearly every case, there is a meningeal foci where bacilli gained access to the subarachnoid space and induced meningitis. Exciting vascular focus in the brain cortex or the meningitis is the key pathway for the tubercular bacilli to enter subarachnoid space. This method of entry is in contrast to the direct hematogenous hematogenic spread typically observed in acute bacterial meningitis. Disseminated tuberculosis plays an important role in the development of tuberculosis meningitis in children. As disseminated tuberculosis increases, the probability that a rich focus will develop was enhancing the chance of continuous repute the lesions leading to clinical TB meningitis. That's it again. Tumor necrosis factor alpha is critical in the neuropathogenesis of Mycobacterium tuberculosis. L3 tumor necrosis factor plays a definitive role in granuloma formation and containment of mycobacterial infection, local central nervous system production of tumor necrosis factor leads to altered blood-brain barrier permeability and cerebral spinal fluid leukocytosis and has been implicated in fostering the progressing of TB meningitis. Distinctive characteristic of Mycobacterium tuberculosis is its capacity to enter and replicate within macrophages, within the central nervous system. Microglial cells are the resident macrophages, and as such, human microglial cells are productively infected with Mycobacterium tuberculosis, and the principal target in the central nervous system tuberculosis. Tuberculosis meningitis is the inflammation of meninges. Up to 80% of patients with tuberculosis meningitis ever have traces of early acute tuberculosis of avlocalization or active tuberculosis of the site. What we must continue about pathogenesis of TB meningitis. The main route of MBT infiltration into the meninges is a hematogenic route. At the same time, the damage of meningeal proceeds in two phases. First, during the first phase, in primary tuberculosis, the sensibilization of an organism developed, and MBT breakthrough brain blood-brain membrane and infection of vascular plexuses of the pia mater takes place. Second phase. During the second phase, MBT from vascular plexus penetrate into the liquor and work specific inflammation of pia mater and the base of brain. We must use the term bacillary meningitis. Bacillary meningitis. Next picture, you can see schematically in this slide. You can see schematically a picture about pathogenesis of TB meningitis. TB meningitis. How Mycobacterium tuberculosis can penetrate into meningia. After the release of tubercle bacilli from granulomatous lesions into the subarachnoid space, a dense gelatinous exudate forms. It is most florid in the interpendicular fossa and suprasellar region anteriorly, and it may extend throughout the prepontine cistern and surround the spinal cord. This exudate envelops arteries and nerves, creating a bottleneck in the flow of cerebral spinal fluid at the level of a tentorial opening, which leads to hydrocephalus. The exudate contains erythrocytes, neutrophils, and macrophages, followed by lymphocytes and more mature exudates. Each foci typically follow the vascular pattern and are located both in the meninges and in the brain parenchyma. Of note, each foci are not preferentially distributed to the basilar areas of the brain where the exudate is typically located. The localization of a tuberculosis exudate to the basilar area is hypothesized to be simply a result of a normal flow pattern of cerebral spinal fluid or liquor. The most serious consequence of TB meningitis, however, is the development of vasculitis in the vessels of a circle of the Willis, the vertebro-basilar system, and the perforating bronchus, the middle cerebral artery, resulting in infection of distribution of those vessels. Direct contact of exudate with the brain surface causes a body zone reaction that damages the underlying brain tissue. Next slide, we can see also schematically picture about pathogenesis of TB meningitis and about pathogenesis of liquor hypertension in brain. What about clinical features of tuberculosis meningitis? There are three main forms of tuberculosis of meninges and central nervous system. First form, basal tuberculosis meningitis. Second form, basal tuberculosis meningoencephalitis. And third form, meningoencephalomyelitis. Meningoencephalomyelitis. Now we must continue about basal tuberculosis meningitis as about first form of TB meningitis. Basal tuberculosis meningitis observed in 26 or between 26 and 32% of cases and is characterized by a combination of meningeal syndrome with brain nerves with damage and related inflammatory changes in cerebrospinal fluid. We also include weakly expressed forms in which cranial nerves are not affected. Basal tuberculosis meningoencephalitis occurs in 60 or 70% of all cases, between all cases. This classic form has not changed to this day, but can cause atypical on background of indiscriminate antibiotic treatment of persons with the unclear etiology disease. In this form, the brain matter, cranial nerves, and the brain substance affects by Mycobacterium tuberculosis. Meningoencephalomyelitis occurs in 4 or 6 percent of between all cases. It can occur in two forms, which differ on the initial symptoms. First form, racing meningoencephalitis, where the first manifestations of disease symptoms of myeloradiculonephritis, urination disorders. Meningeal symptoms are joined later, a few weeks or even months. This group of patients has psychomotor agitation as one of the first distributional process in the brain science. We think meningoencephalomyelitis is very difficult to diagnose at the beginning, especially. And what about second form of meningoencephalomyelitis? encephalomyelitis. This form characterized by the process spread from the base of the brain to the spinal cord membranes, and also predominance in the clinical picture of the disease symptoms of membranes and substance of the brain and spinal cord damage. The clinical features of TB meningitis are the result of basilar meningeal fibrosis and vascular inflammation. Tuberculosis meningitis is typically a subacute disease, and especially we have a large problem with diagnosis of TB meningitis in children, because as a rule, this form of disease this form of TB meningitis start from very small symptoms such as headache and small fatigue, small problems with memory, and as a rule, headache start from small symptoms, but every day the intensity of headache increasing, and in late phase, sometime when meningoencephalomyelitis start, we can't help patient. We can't help patient with promedol, not only with with anti-inflammatory drugs. We can't help when we use morphine and promedol also. Very intensive headache start in late phase. I must repeat, TB meningitis as a rule start as subacute disease. Prodromal phase with a low-grade fever, malaise, headache, small headache, I must repeat, in initial phase, vomiting, and or personality change may persist for a few weeks, after which inpatient can develop more severe headache, alterated mental status, stroke, hydrocephalus, and cranial neuropathies. Seizures are uncommon manifestation of tuberculosis meningitis in adults, and when present should prompt the clinician to consider alternate diagnoses such as bacterial or viral meningitis or cerebral tuberculoma. In contrast, seizures are commonly seen in children with TB meningitis, occurring in up to 50% of pediatric cases. Classic features of bacterial meningitis, such as stiff neck and fever, may be absent in case of TB meningitis. When allowed to progress of disease without treatment, coma and death almost always ensue. In survivors of TB meningitis, neurologic sequelae may occur, which include mental retardation in children, sensory neural hearing loss, hydrocephalus, cranial nerve palsies, stroke associated lateralization neurological deficits, cirrhosis, and coma, also coma possible. The diagnosis of TB meningitis can be difficult and may be based only on clinical and preliminary cerebral spinal fluid findings without definitive microbiological confirmation. Certain clinical characteristics such as a longer duration of symptoms, more than 6 days, moderates pre-cytosis in cerebral spinal fluid, and the presence of focal deficits increase the probability of TB meningitis. Also, I prepare for you table with clinical features of TB meningitis in children and adult patients. In this table, we can see main symptoms in children and main symptoms in adult patients, clinical findings, and main findings in cerebrospinal fluid. I can't stop in this table because big information present. I prepare this information for you, and we must use this information on our class. Characteristic of we must continue about main characteristic of cerebrospinal fluid findings of in patient with TB meningitis. At first, cerebrospinal fluid looks clear, but may forms a spider's web clot on standings. Next, lymphocyte predominant pleocytosis. Total white cells counts are usually between 100 and 500 cells microliter. Norma has up to 5 only. Very early in the disease, low counts and neutrophil predominance may be present. Next, elevated protein levels, typically between 100 and 500 milligram or between 1 or 2 gram per liter. And what about normal? Between 0.15 0.45 gram per liter. Next signs. Low glucose. The glucose in cerebral spinal fluid decrease. Low glucose, usually less than 45 milligram per deciliter. Next, at a bacteriological examination, MBT are revealed only in 10 cases if volume of cerebral spinal fluid is sufficient, 10, or if we're using 10 or 12 milliliters of spinal fluid. The methods of centrifugate flotation during 30 minutes on high speed can reveal MBT in spinal fluid in 90 cases. Early diagnosis, we must use lumbar puncture. If we have especially if we have information about contact with TB patient, we must use not only clinical symptoms, not only patient's complaints, information about patient's complaints, clinical symptoms, results of inspection, and laboratory diagnosis. We must use especially lumbar puncture because we need in diagnosis of cerebral of change in cerebral spinal fluid. And we must take patient's liquor, patient's spinal fluid into three tubes for spinal fluid. How many milliliters we must take? We must take not less than 6 milliliters of spinal fluid. And why we must use 3 tubes for diagnosis? 3 tubes for diagnosis of changes in spinal fluid. We must detect changes with cells in patients' spinal fluid. We must detect biochemical changes in his spinal fluid, and we must try to find mycobacterium in his spinal fluid. So we must use two tubes with fluid in clinical laboratory and one tube in bacteriological laboratory, because we must detect Mycobacterium tuberculosis in patient's spinal fluid. You must remember, we detect Mycobacterium tuberculosis as rule only in 10% of all cases of TB meningitis. What about differential diagnosis of TB meningitis? The main conditions to be differentiated are bacterial meningitis, viral meningitis, and HIV-related cryptococcal meningitis. In the first two, that is much more acute forms. Viral meningitis and bacterial meningitis as a rule with acute start and acute clinical symptoms, but TB meningitis with asymptomatically beginning or with very small symptoms, Cryptococcal meningitis may have a much slower onset. If a family history of tuberculosis or the finding of tuberculosis somewhere else in the body makes tuberculosis meningitis much more likely. But the important evidence comes from examination of cerebral spinal fluid obtained by lumbar puncture. About main parameters of cerebral spinal fluid in patient with different form of meningitis. This information I prepare in next table. You can see main parameters of cerebral spinal fluid. You can see also normal indicators. Next, also main changes in patient with TB meningitis, in patient with bacterial meningitis, viral meningitis, and fungal meningitis. What about some words also about differential diagnosis of TB meningitis? You must remember bacterial meningitis and viral meningitis with acute start. TB meningitis start slowly with from small symptoms. What about clinical symptoms, intensivity of clinical symptoms in patient with TB meningitis increasing. The duration of TB meningitis very long, especially if our patient without early diagnosis, without treatment. If our patient without treatment, as a rule, patient died. Bacterial meningitis. What's the main cause of bacterial meningitis? Not only a meningococcal infection, meningococcus, different bacterial infection, such as Escherichia coli. More often we detect Escherichia coli as the cause of bacterial meningitis. Different bacteria can be as the cause of bacterial meningitis. Viral meningitis. The cause of viral meningitis, different virus. Cytomegalovirus, for example, herpes zoster, different virus. Next, fungal meningitis. As a rule, we detect cryptococcus. Acute start, we detect in patients with bacterial meningitis and viral meningitis. Clinical symptoms are also acute in patients with bacterial meningitis and viral meningitis. What about clinical symptoms? Clinical symptoms start early and very early clinical symptoms. What about intoxication? A very hard intoxication we detect in patient with bacterial meningitis. You must remember very hard intoxication in patient, very hard and with acute start. Very hard intoxication and with acute start of symptoms of intoxication we detect in patient with bacterial meningitis. Viral meningitis, symptoms of intoxication, intensivity of intoxication, also acute, but not so acute as in patient with bacterial meningitis. And what about TB meningitis? In the case of TB meningitis, symptoms of intoxication start slowly, but every day increasing. Next, about pleocytosis in cerebral spinal fluid. Very high pleocytosis, you must remember, in patient with bacterial meningitis. Sometimes we can't detect how many cells in patient's spinal fluid. We can't detect. Sometimes more than 100 of thousands. What about TB meningitis? TB meningitis, as a rule, we detect several hundreds of cells in spinal fluid, and as a rule, several hundreds, and only in patient with PM meningitis, we detect sometime 1,000 or 2,000 cells in spinal fluid. In patient with viral meningitis and fungal meningitis, pleocytosis near several hundred, sometimes several thousands, Next, what's so important for us? Also, protein in cerebral spinal fluid. Very high level of protein we can detect in patient with TB meningitis. We can see that protein increasing in cerebral spinal fluid in patients with bacterial meningitis and viral meningitis also. What about glucose? A very low level of glucose in patient with TB meningitis. And what about the results of treatment? We must use anti-TB drugs for treatment of TB meningitis, and we must use antibiotics for treatment of bacterial meningitis. For patient we must with viral meningitis, we must use non-specific treatment because we can't detect the type of virus as the cause of patient's disease. I must continue about TB meningitis. TB meningitis, we must start treatment early. so early as this possible. If we detect contact with TB patient, we must think about TB meningitis, and we must start chemotherapy. If we haven't this information about contact with TB patient, but we detect clinical symptoms characterized for TB meningitis, and we detect slow beginning of slow start of clinical symptoms from small headache, and if we detect those changes in children especially, and also in adult patient with HIV, so we must think about TB meningitis, and we can't exclude TB meningitis. For example, we can't detect TB meningitis, we can't find mycobacterium in spinal fluid, but we think about TB meningitis because clinical symptoms are characterized for TB meningitis. In this situation, we must start chemotherapy, not so correct, chemoprophylaxis. For example, later we detect the cause of patient's problem. For example, fungal meningitis or viral, atypical form of viral meningitis. So no problem in this case. If we start only chemoprophylaxis, chemoprevention, what it means? Chemoprevention, chemoprophylaxis, chemoprevention. In this case, we must use, students, please attentively, not about treatment now. Only in difficult situation when we can't detect main cause of patient's meningitis, but we think about TB as possible diagnosis. In this situation, we must use chemoprophylaxis or chemoprevention. This prevention, chemoprophylaxis, chemoprevention includes two main anti-TB drugs. What main anti-TB drugs we must use? Isoniazid and rifampicin. What ways for injection we must use? Main way, parenteral way. We must use a half daily dose intravenously, and if this possible, if we have a form of isoniazid and rifampicin, injected form of isoniazid and rifampicin. And second half dose, we must use Peros in tablets. If this is impossible, for example, isoniazid and rifampicin in injected forms absent, for example. In this case, we must use chemoprophylaxis, only Peros. We must use daily doses of isoniazid and rifampicin according, I must repeat, according to patient's weight only. We must use isoniazid and rifampicin daily doses of those drugs, Peros only in this case, if injection form for injection will be absent. Now about several words about the treatment of TB meningitis. If we detect TB meningitis, we must use chemoprevention, regime of chemoprevention. If we detect the risk of drug resistance tuberculosis, in this case, we must use regime number 4. And we can't use isoniazid and rifampicin because our patient with drug resistance for those drugs or with high risk of multi-drug resistance tuberculosis. We must try to find mycobacterium and spinal fluid, if it is possible. If we can find, we must detect sensitivity of patient's mycobacterium for different anti-TB drugs and antibiotics. And only according to sensitivity of Mycobacterium tuberculosis, we must use treatment. If risk of multi-drug resistance tuberculosis absent, we must use regime number 3, first regime or second regime, according to sensitivity of Mycobacterium tuberculosis. If we detect Mycobacterium tuberculosis, we must detect sensitivity of Mycobacterium tuberculosis for anti-TB drugs. How long we must use chemotherapy regimes of chemotherapy in a long time? More than 12 months as a rule. First phase and second phase of chemotherapy will be longer. Sometime near 18 months or 2 years. 2 years. What else important? Best variant. If we're using main anti-TB drugs intravenously, half dose and half dose peros. We must use full regime. What it means? 4 anti-TB drugs. 4 anti-TB drugs. If our patient with sensitivity of Mycobacterium, sensitivity for anti-TB drugs. If our patient with drug resistance, multi-drug resistance, or extensively drug resistance tuberculosis, in this case, sometimes we must use 5 or 6 anti-TB drugs and antibiotics. What we must use for treatment? Not only a regime of chemotherapy, main treatment. Very important treatment, very important treatment for patient with TB meningitis. Lumbar puncture. We must use lumbar puncture not only for as a method of diagnosis. We must use lumbar puncture as methods of treatment for patient with TB meningitis. Why? Because we must decrease pressure pressure of spinal fluid in spinal cord. And we can't help a patient with drugs only. Why? Because the producing of spinal fluid continue. We must use lumbar puncture very often. How often? At first week, every 2 or 3 days. 1 lumbar puncture every 2 or 3 days. At next time, every week. At next time, every 2 weeks. Next time, every 3 weeks. Every month. And how long we must use lumbar puncture? Well, when patient recovery only, full recovery, we detect full recovery. So in this case only, we must stop these methods. You must remember we must use a lumbar puncture not only for diagnosis, but also as important methods of treatment. Next, we must use also different pathogenic therapy and symptomatic therapy. And we can't use physiotherapy. What about prognosis? Fatal outcome is certain if the patient does not receive treatment. When early meningitis is diagnosed and treated, the more likely is the patient to recover without serious permanent damage. The clearer the state of consequences when treatment is started, the better the prognosis. If our patient is in coma, the prognosis for complete recovery will be poor. I think enough about TB meningitis. Very difficult question. TB meningitis, very difficult question. And answer you must read information in your books and from another source from internet also. Now we must continue about brain tuberculoma. Tuberculomas are thought to arise when tuberculosis in the brain parenchyma enlarge without rupturing into the subarachnoid space. As such, they often occur in the absence of TB meningitis, but certainly may occur along with tuberculosis meningitis. They more commonly arise as solitary lesions, but multiplied tuberculomas are seen also. Tuberculomas of the brain show a typical granulomatosis reaction consisting of epithelioid cells and giant cells mixed with predominantly lymphocytes around a central area of caseating necrosis. Any liquefaction of a central area of necrosis contains clear or strong colored fluid as opposed to pus. In the early stage, it is much small, the late grade. The average diameter of brain tuberculoma is 0.5 or millimeters or 1 centimeter. Sometimes we detect brain tuberculomas with large, big size, more than 1 centimeter. Although the size can reach 4 centimeters. Mostly there are solitary brain tuberculomas, although they may be multiplied. As in lungs, sometimes we detect solitary tuberculoma, sometimes we detect multiplied tuberculomas. The disease, what about clinical symptoms of brain tuberculoma? The disease begins with a prodromal period to an average of 1 or 2 months. When clinical symptoms start? As a rule, clinical symptoms start as a result of compression of different structures in brain. And so, from the compression of from this depend first and main clinical symptoms. From compressed place, compressed important structures of brain. The disease begins with a prodromal period to an average of 1 or 2 months, I must repeat. The first clinical symptom, the signs are weak, asthenia, conduct disorders, lethargy, sleeping. Sometimes we detect lethargy, sleeping, irritability, The beginning of a disease can be acute with the rapid increase of symptoms and subacute with prolonged symptoms less course and with slow progression of some disease symptoms. If there is supratentorial tuberculoma disease manifested with focal symptoms, irritation in the forms of convulsive attacks and hallucination. What about diagnosis of brain tuberculoma? Diagnosis depends from the start of clinical symptoms. Patients' complaints depend from the start of clinical symptoms. And when complaints start, when compression start in brain, compression of different important structures of brain. Diagnosis is based on anamnesis. Very important for us information about contact with TB patient, about first case of TB in this patient, for example, now maybe relapsing tuberculosis as brain tuberculoma, as variant of brain tuberculoma. Also, very important information, where this patient working. For example, he have contact with TB patient or with TB animals. Also very important information. Also very important for us, slowly disease course. Subacute start or asymptomatically start. Very important for us information we take from X-ray, computer tomography, and when we use MRI. We can detect changes in patient's brain in different structures. We can detect the size of those changes. Also, we can detect compression of important structures. We can use also for diagnosis, we can use electroencephalography and other methods if we need for final diagnosis, if we need. In this picture, we can see multiplied tuberculosis, multiplied tuberculosis in patient with generalized tuberculosis. What about prognosis in this case? Very bad prognosis, without prognosis. We must use chemotherapy. We must use chemotherapy for treatment, but you must remember that tuberculoma, this is clinical form with capsule. So our anti-TB drugs can't penetrate through fibrotic capsule, through dense capsule with big fibrosis. So we must use chemotherapy. But what about result? If the capsule of tuberculomas will be very dense, so result will be not so good. Effectiveness will be very low because our drugs can't penetrate into tuberculomas. Such patients need surgical treatment, but how is possible in this case? If our patient with multiple tuberculomas, it is impossible. We're using surgical treatment not so often for patients with solitary tuberculoma, brain tuberculoma. When we must use surgical treatment, surgery, only if the symptoms of compression, of brain compression, will be very hard. and we need in this treatment and surgery. But must understand that this very dangerous procedure, this treatment very dangerous, and we must continue chemotherapy and different pathogenic and symptomatically types of treatment, variants of treatment. Next clinical form of TB of central nervous system, tuberculosis brain abscess. Tuberculosis brain abscess. We detect this form very rarely. Brain abscess formation is a rare manifestation of central nervous system tuberculosis. Tuberculosis brain abscess develops either from parenchymal tubercular granulomas or via the spread of tuberculosis foci from the meninges, and is characterized by an encapsulated collection of pus containing bacilli without evidence of a classic tubercular granuloma, and must be distinguished from granuloma with central causation and liquefaction mimicking pus. Brain abscesses can arise as solitary or multiply lesions. In case of lung tuberculoma, we must differentiate lung tuberculoma with different cystis and with parasitic, non-parasitic cystis and lung abscess. In case of brain tuberculoma, we must differentiate brain tuberculoma with different cystis and with tuberculosis brain abscess and non-tuberculosis brain abscess, and with non-tuberculosis brain abscess. And also students with tumor, different tumors, especially non-malignant tumor, because non-malignant tumor grows in capsule. Radiologically, tuberculosis brain abscess has a much thicker abscess wall than a pyogenic brain abscess. Histopathological findings suggest that the inflammatory reaction in the abscess wall is predominantly vascular granulation tissue containing acute and chronic inflammatory cells and bacilli in the pus or abscess wall. The clinical cause of similar to brain tuberculoma is similar to brain tuberculoma. Next, final form of central nervous system tuberculosis, tuberculosis encephalopathy. It belongs to a group of tuberculosis allergic manifestations. It occurs in children and adolescents as well. The main symptoms include disorders of consequences and coma, sometimes coma. Brain abscess formation is a rare manifestation of central nervous system tuberculosis. Central nervous system tuberculosis. Now we, I think, enough about TB of central nervous system. You can read information also in your books and in internet source. And you must prepare for your first class full information. Now we must continue about different clinical forms of extrapulmonary tuberculosis. Only short information because this is impossible to prepare full information about all forms of pulmonary TB. Many clinical forms of extrapulmonary tuberculosis. Only short information because big information, large information in your books and internet, different information present. TB of peripheral lymph nodes. TB of peripheral lymph nodes. Tuberculosis of lymphatic nodes, most human Mycobacterium tuberculosis also. In place with a bad episodic situation of tuberculosis, an important place in the development of tuberculosis of peripheral lymphatic nodes is acute by Mycobacterium of bovine species, Calmid or Calmid bacillus. Infection with tuberculosis of lymphatic nodes occurs by lymphohematogenic way. Tuberculosis of lymphatic nodes most often causes a human Mycobacterium tuberculosis. Different groups of peripheral lymph nodes can be affected by Mycobacterium tuberculosis. When we detect TB of peripheral lymph nodes, sometimes as first changes in patient's body. When this possible, more often in patient with HIV. In patient with HIV, when in patient's lungs, TB process will be absent, but all groups of lymph nodes, of peripheral lymph nodes, will be affected. This is possible in patient with HIV infection. When else TB of peripheral lymph nodes possible? As a result of relapse, of relapsing tuberculosis. In patients who have different forms of lung tuberculosis, different clinical forms of lung tuberculosis. And also in patient as one form between different forms in patient with generalized tuberculosis. In this picture, you can see different groups of peripheral lymph nodes. All groups of lymph nodes can be affected, all groups. More often, peripheral lymph nodes, subclavian lymph nodes, TB, peripheral lymph nodes, all groups of necks, in neck. Also, axillary lymphatic nodes. In general, lymphatic nodes, different lymph nodes can be affected. You can see statistic, according to statistics, as a rule, we detect TB of peripheral lymph nodes, lymphatic nodes of neck will be affected, especially anterior group. What we can see in these pictures? Affected next lymph nodes, axillary lymph nodes, and inguinal. As a rule, this clinical form characterized by late diagnosis. Patient can't think about TB if he detects changes with his lymph nodes. And if treatment absent, will be absent, what possible? evaporation, our lymph nodes, the skin becomes hyperemia. We detect hyperemia. Next, fluctuation start. The pus break out. Fistulas formed. We can see in this picture enlarged peripheral lymph nodes on neck with intensive caseous process. And we can see this picture before formation of fistula. And long-lasting non-healing fistulas are formed. When fistula closed, what we can see in this place? We can see fibrosis scars. As a rule, keloid scars. These will be, we must attentively when we start inspection of each patient, because we can detect scars on patient's neck. What it means? Maybe TB meningitis, TB of peripheral lymph nodes was. Next. Awesome. TB of peripheral nodes. Neck group, and axillary. Next, what about the diagnosis? We must use patient's complaints. We must use full information from anamnesis of his disease, anamnesis of his life. We must use inspection. We must use laboratory diagnosis. What change in blood? We must detect urine test, and we must use sputum examination, and we must use puncture of peripheral lymph nodes, because we can detect Mycobacterium tuberculosis. And if we detect Mycobacterium tuberculosis when we're using puncture of lymph nodes, we must change tactic of our treatment. We must start treatment from chemotherapy, but we must use not only chemotherapy, we must use surgical treatment, lymphadenectomy. We must use lymphadenectomy. Also, what we must use for the early diagnosis? Ultrasound. Students. As a result of inspection, we can see enlarged peripheral lymph nodes. We must use palpation of peripheral lymph nodes, not only affected lymph nodes, all groups. What we can detect on palpation? Sometimes we can detect conglomerates, not only one enlarged lymph node. We can detect conglomerates of lymph nodes. We can detect several enlarged lymph nodes. This depends from patient's situation, patient's condition. Next, when we using ultrasound diagnosis, we can detect the size of affected lymph nodes. We can detect the structure. We can detect that decay phase start in lymph nodes. Next, what else we must use for diagnosis? If we detect patient with fistulas, we must use fistulography with contrast. Next, on X-ray, if our patient with all changes in his peripheral lymph nodes, we can detect not only change in his chest, for example, our patient with TB in his lungs also. And when we using X-ray of neck, X-ray or computer tomography, we can detect, especially if we're using X-ray of neck, we can detect calcinates of as a result of TB evolution. Inflammation, next time inflammation must decrease and calcination start. And next time, and fibrotic change start in affected lymph nodes. And next time we can palpate dense lymph nodes, conglomerates of several lymph nodes, and on X-ray we can detect calcinates. When we're using CT scan, we can detect the size of lymph nodes, affected lymph nodes. We can detect change in affected lymph nodes. We can detect calcination in affected lymph nodes. And we can detect the density of calcination, because this is very important for diagnosis, especially for differential diagnosis. Next, about also we must detect changes in surrounding tissue. For example, maybe inflammation start, TB inflammation start in salivary gland. TB of salivary gland also start. So our next treatment will be depend from result of instrumental diagnosis also. About differential diagnosis, we must differentiate with non-specific lymphadenitis, with infection mononucleosis. Next, we must differentiate with metastasis of different tumors, malignant tumors, and with different infection. We must differentiate especially with HIV and our infection, cytomegalovirus infection and our. Next, what about treatment? We must start from chemotherapy, but we must use, as a rule, if we detect patient's problem late, especially late, we must use surgical treatment. If the result of our treatment will be not so good, not so high, we must use surgical treatment, surgery. And if we detect our patient very late, so we must use not only chemotherapy, also surgical treatment, lymphadenectomy. Prognosis depend from patient's condition. If our patient only with TB of lymph nodes, and our patient without HIV infection, so patient recovery, as a rule, prognosis will be good. If our patient with generalized tuberculosis or with generalized tuberculosis and HIV infection, prognosis will be very bad, as a rule, patient died. What complications possible? This clinical form very dangerous, especially if we detect TB of peripheral lymph nodes in patient's neck, because very high risk of TB meningitis, especially in immunosuppression, in patient with immune suppression, TB meningitis, and also meningoencephalitis, brain tuberculoma, very high risk. Next, I think enough about TB of peripheral lymph nodes. Also, big information present in your books and internet. Now, several pictures and several words about TB of bones and joints, spine tuberculosis. Very tight. Clinical form of TB of bones and joints. On first place, according to statistical, on first place will be spine tuberculosis. And also afterward, TB of hip joint, TB of knee joint. Knee. Why? What parts of spine as rule affected? Where as rule we can detect TB process? In lumbar part and in patient's thoracic part, chest part. Why? Because the vertebra in lumbar part of spine with big, large body. What it means? It means good, very intensive microcirculation, blood microcirculation. So mycobacterium like those places. And TB start. What about risk group? Risk group of TB. Patient with trauma of spine, patient with different disease of spine, with high risk of TB, spine tuberculosis. And patient with lung tuberculosis. As a result of progression of TB process, sometimes we detect spine tuberculosis. Sometimes spine tuberculosis start without changes in patient's lungs. Yes, this is also possible. What about small joints? About effect of small joints. TB of small joints also possible, but not so often. Not so often. What about diagnosis? Diagnosis is rule late diagnosis of spine tuberculosis, of TB of different joints and different bones. Why? Because in a long time, patients have asymptomatic picture. And when clinical symptoms start, patients and clinicians can't think about TB. They think about non-specific inflammation. And as a rule, doctors start the treatment of non-specific inflammation. We lost time. Sometimes we lost big time, large time. And sometimes we detect rush of vertebra. You can see in this tomogram result of late diagnosis. Result of late diagnosis. Next. You can see in those pictures large deformation of spine. This is the result of spine tuberculosis, which start in childhood. Pathology, lordosis start. Pathology, lordosis. Pathology, kyphosis. Pathology, lordosis. What deformation possible? Scoliosis, pathology, lordosis, pathology, kyphosis. What we can detect also when we start inspection? Not only scoliosis or kyphosis, lordosis, pathology, lordosis, pathology, kyphosis. Sometimes we can detect cold abscess near affected vertebra or in some low level, more low level. What it means? Cold abscess. And how we can detect cold abscess? We can detect cold abscess on palpation in time of inspection, and we can detect cold abscess on X-ray or on CT when we using MRI also. Next, what about diagnosis? Spine tuberculosis, TB of hip joint, knee. We must differentiate with non-specific inflammation, with osteoarthritis. Next, with different tumors, with mycobacteriosis sometimes, and with metastasis of malignant tumors. What about treatment? Students, diagnosis is sometimes very, very difficult, especially if in patients' lungs tuberculosis process absent and we can't find mycobacterium in patient's sputum or in now fluid in urine, in fluid, for example, from fistula, from cold abscess fistula. For example, if we can't find mycobacterium, so diagnosis sometimes will be very, very difficult and late. What about treatment? With treatment, our tactics depend from result of late diagnosis. If we detect patient's problem earlier, so the treatment, we must use only chemotherapy and result of treatment will be good. Patient can recover. But if diagnosis will be late, we detect different complications and we must use not only chemotherapy, we must use also surgical treatment. High technology medical. Yeah. In those pictures, we can see also clinical forms of bones tuberculosis or TB of bones, TB of finger, as will be detected in small patient and children, spine tuberculosis. In this picture, also spine tuberculosis, TB of finger and of his foot. Clinical forms of skin tuberculosis. This group includes also primary forms and secondary forms of skin tuberculosis. Mycobacterium tuberculosis enters the skin and the mucous membrane more often by hematogenic, lymphogenic ways, or by percontinuity from the underlying organs and tissue affected by tuberculosis. In this picture, we can see lupus erythematosus. Lupus erythematosus, very hard clinical form of TB. Very hard and very dangerous clinical form of TB. Why? Because only in this case we can detect malignant tumor, such as sorry. Lupus carcinoma. Lupus carcinomas. When these clinical forms start? As a rule, in patients with immune deficiency, different types of immune deficiency condition, such as patient with HIV. If next group, if our patient is treated with different immunosuppressive drugs, for example, cytostatics, glucocorticosteroids, biological gene engineering drugs, if we're using radiation therapy for treatment of malignant tumor, for example. So this patient with high risk of generalized tuberculosis and skin tuberculosis too. You can see in those pictures also lupus erythematosus, ulcer damage. In this picture, we can see pathognomic phenomenon, apple jelly. Apple jelly. We can see now the color of apple jelly when we this pathognomic phenomenon. Also, next variants of lupus tuberculosis, exudative necrotic form of tuberculosis lupus, and ulcerative form. After that form, as a rule, carcinoma can start, especially if our patient without correct treatment, in a long time without correct treatment. Or tuberculosis of the skin, near fingers, or tuberculosis of the skin. Next, miliary ulcer tuberculosis of the skin and lichenoid tuberculosis of the skin. Some words about tuberculosis pleurisy. I'm very, very tired. Sorry. Pleurisy is the inflammation of pleura. Two basic forms of pleurisy are distinguished. Pleuritis sicca, fibrinous, and exudative form. Where from infection in pleura And what pleura as a rule will be affected? Parietal or visceral pleura? Please remember, parietal pleura as a rule will be affected more often. Why? Because mycobacterium penetrate from different foci in patients' lungs as a rule can penetrate into pleura by lymphatic vessels. Sometimes from old changes in patient's lungs and old foci in patient's lung tissue, or from old changes in intrathoracic lymphatic nodes. More often we detect changes such as tuberculosis in parietal pleura. When inflammation starts in visceral pleura, as a rule, as a result of perifocal inflammation. When our patient with TB, different form of secondary tuberculosis, lung tuberculosis, and when his TB changes, locates near pleura in subpleural place, in subpleural places. Exudative inflammative reaction of a pleura is connected with increased permeability of the blood and lymphatic capillaries of lungs, cortical layer, and pleura itself. Thus, capillaries make way for a liquid part of blood into interstitial fissures, superficial layer of pleura, and with the help of negative pressure into pleural cavity. Lymphogenic pleurisy. With tubercular infection can affect subpleural lymphatic nodes, accumulating in the nodes Mycobacterium tuberculosis. Some break up and are eliminated the rest of Mycobacterium tuberculosis, keeping their virulence, and distributed along lymph vessels causes subpleural cortical lymphangitis of exudative pleurisy. Hematogenic pleurisy. Next, hematogenic pleurisy. Hematogenic spreading of MBT into the pleural cavity promotes the development of tuberculosis on the pleura. The initial focus is an active tubercle process in mediastinum lymphatic nodes. Contact way of MBT dissemination rises at active tuberculosis of lymphatic mediastinum nodes, intrathoracic lymph nodes, with defeat of visceral pleura. Dry pleurisy, fibrinous pleurisy. This form of it's a fibrinous pleurisy. On the pleura, it shows gentle layers of fibrinous structure, which could remove fibrinous pellicle of yellowish or yellowish gray color is formed. Small tubercles with a small size near 2 millimeters, 3 millimeters with yellow color. Purulent pleurisy or empyema from the very beginning arises as purulent, very rare, but more often it develops after serous fibrinous inflammation of a pleura. The process usually happens lateral and settles in basal or posterior parts of pleural cavity. The purulent pleurisy is absolute at bursting of gaseous masses from lung into a pleural cavity, bronchial fistulas, and hemorrhagic pleurisy, accompanied by penetration of exudates, can take of significant quantity of erythrocytes into pleural cavity. Chronic pleurisy form often chronic course of disease, absolute pleural empyema. In worse cases, exudates condense, dissociate, turning cheesy mass or thin gel with presence of cholesterol crystals. The microorganism can disappear. The pleural membranes are considerably thickened and dense, sometimes with focal petrification and even calcification. The significant sediment of calcified masses are especially typical for tubercular empyema. The pleural empyema can lead to purulent resorption fever, sepsis, distribution, amyloidosis of internal organs. Sometimes long chronic occurrence is observed at serious fibrotic and fibrotic pleurisy. Next picture, we can see photo as a result of video thoracoscopy, exudative pleurisy, exudative form of pleuritis, exudative form. Clinical symptoms of TB pleurisy depend from form of TB pleurisy. Patient with dry form have large, big pain in chest, intensive chest pain, febrile temperature, and symptoms of TB intoxication. Diagnosis of pleurisy not so difficult, but what's problem in this case? We have difficult diagnosis of TB pleurisy because we must detect the main cause of patient's problem, of patient's changes. And this process is very difficult. What about exudative form? Exudative form with also with large clinical symptoms, with acute start from very high temperature, patient with sometimes with hectic temperature, 39, 40, with acute intensive symptoms of intoxication, headache, dyspnea, fatigue, weakness, hard weakness. If patient with dry form of TB pleurisy, those patients have dry cough and with this cough with pain. Patient with exudative form have hard dyspnea, sometimes hard dyspnea. Dyspnea, many patients with dyspnea and some patients with hard dyspnea. Why? This depends from the volume of exudate in pleural cavity. What change start? Not only exudate in patient's pleural cavity, also atelectasis of this lung also start. Lung in this side. More often we detect TB pleurisy in one side of chest. So, in pleural cavity, exudate increasing, and atelectasis of lungs start and progressing. What about laboratory diagnosis? You must remember when we're using a lumbar, I'm tired. When we're using puncture of chest, we must take fluid from a patient's pleural cavity. But you must remember, we find mycobacterium only in 10% of patients, in 10% of all cases of TB pleurisy. In exudate, we detect mycobacterium not so often. What about differential diagnosis? We must differentiate TB pleurisy with non-specific pleurisy. And exudative form, we must differentiate with mesothelioma of pleura. Mesothelioma of pleura. What is it? Malignant tumor. Malignant tumor of pleura. When we detect also fluid in pleural cavity, we detect symptoms of intoxication, not so high body temperature, and you must remember, exudative form of TB pleurisy as a rule start in young men. More often we detect in young men, but mesothelioma of pleura, as a rule, we detect in old women. What about treatment? We must use chemotherapy. In case of exudative form, we must use puncture. We must take fluid, exudate from pleural cavity. Sometimes we must repeat, several times we must repeat pleural puncture. And we must take, every time we must take fluid from pleural cavity as prevention of lung atelectasis. In time of pleural puncture, we must inject into pleural cavity. We must using instillation into pleural cavity, instillation of anti-TB drugs into pleural cavity. These methods will be very effective for treatment, for effectiveness of treatment. And the prognosis as a rule, good prognosis. This depends from patient's condition. If TB pleurisy only one form between different forms of generalized tuberculosis, so in this case prognosis not so good, as a rule bad. And if TB pleurisy start in patient with HIV, so prognosis also bad, as a rule bad. Next form, clinical form, eye tuberculosis. We can see in those pictures eye tuberculosis. What we must use? We must use clinical manifestation different. We must use inspection. We must use patient's complaints, anamnesis, especially information about contact with TB patient, TB animals. We must use results of inspection. We must use laboratory diagnosis. And also skin tests. We must try to find change in patient's chest as a rule, because as a rule TB, eye tuberculosis start as a result of dissemination, as a result of MBT dissemination. What about treatment? As a result of treatment, good result of treatment, patient recovery. This depends from his condition, his immunity, his condition, and from sensitivity of his mycobacterium, sensitivity for anti-TB drugs. You must remember, students, our clinical forms of extrapulmonary tuberculosis will be presented next several slides also. As a rule, many forms of extrapulmonary tuberculosis, of pulmonary tuberculosis, characterized by the presence of various masks of tuberculosis. Different masks, for example, masks of influenza. When we detect mask of influenza in patient with TB, in patient with miliary tuberculosis, and in patient with exudative form of TB pleurisy, mask of pyelonephritis, when we detect this mask in patient with TB of kidney, mask of rheumatoid arthritis in patient with TB of hip joint, knee joint, and other mask, different mask of polycerasitis, mask of pathology of pleura in patient with different form of TB pleurisy, masks of vegetal neurosis in a small patient, as a rule in small patient with in children with latent tuberculosis infection or primary tuberculosis infection in children with TB of intrathoracic lymph nodes. Also, all clinical forms of TB characterized by late diagnosis as a rule, especially extrapulmonary form. Why? Because we're using screening, fluorography for diagnosis for early detection of tuberculosis changes in patients' chest. But sometimes we have big problem with diagnosis of extrapulmonary tuberculosis. And as a consequence, there is a need to use not only anti-tuberculosis drugs, but also high-tech complex surgical treatment and other treatment methods. You can see in this photo, you can see hard cachexia. Who this patient with generalized form of TB. Not only his lungs were affected, the other organs and other organs also. Who this small patient with TB meningitis, You can see hard cachexia, habitus phthysicus. We can see changes of his chest, acute angle between fibra. We can see retraction of fossa, subclavian, supraclavian fossa, retraction of intercostal space. We can see hard muscles atrophy, only bones, joints, and skin. Sometimes injections impossible. When patient with hard fibrous cavernous tuberculosis, with chronic disseminated tuberculosis, with generalized form of TB, tuberculosis is not always affected but only by one organ. Often there is a dissemination of mycobacterium and the progress of tuberculosis process As a result, the patient has the development of generalized tuberculosis. What is it, generalized tuberculosis? This is the case when the patient has tuberculosis of 3 and more localization. When we detect 3 and more clinical forms of TB at one time in this patient, so we must use definition disseminated tuberculosis, 3 and more clinical forms. If we detect 2 clinical forms of TB, we must use definition combined tuberculosis. Combined tuberculosis. And also, I must continue about one clinical case about 31 years old young woman who had following localization of tuberculosis process: pulmonary tuberculosis, skin tuberculosis, lupus erythematosus, tuberculosis of right ear, also tuberculosis kidney and spine, as revealed in autopsy. And we can see with photo this patient, this young woman, we detect in our tuberculosis in our republic. She was hospitalized into our tuberculosis anti-tuberculosis dispensary. Her TB, the result, her generalized tuberculosis, this is the result of a treatment of rheumatoid arthritis, autoimmune problem. In Moscow, doctors used for this patient biological genetic drugs, and after 1 month after that, in this young woman, firstly, skin problems start. She was hospitalized into hospital. After that, tuberculosis of after that, in her right ear, problems start in her right ear, and doctors used bacterioscopy, and on bacterioscopy in Rozayevka, clinicians detect Mycobacterium tuberculosis in fluid from ear and in fluid from ulcers, skin ulcers. Wait, what we detected? We detect resistance for anti-TB drugs. Late, we detect resistance for 8 anti-TB drugs. We're using best drugs for this woman, and the results of treatment were good. But some late, this young woman died. Why? Because some young men, some young women likes to use internet and different methods of treatment. She finished her treatment because she used voices, and after 6 or 7 weeks, she died. Skin tuberculosis, lupus erythematosus, as a result of tuberculosis process, tuberculosis of her skin. Also, you can see a large ulcer on skin. And thank you.